good afternoon, and it's really a pleasure to be here. Thank you for the invitation.
Don't try not to get bothered. It should just turn right back on.
Okay. So I'm going to talk about non-contributory pension programs. They are equivalent to SSI, the Supplemental Security Income Program for poor older adults in the U.S. So in this project, we work with the Mexican government in the south of Mexico to introduce this non-contributory pension program. To some, we have treatment and control groups, and then the goal of the project was to evaluate, or has been to evaluate the effects on health and other outcomes. So I will mention, I'll give you a brief summary of some of the results that we have so far, and then I'll concentrate on the paper we're currently working. So non-contributory pension programs, because of the aging of the population around the world, have become one of the main poverty alleviation programs for older adults, particularly in low and middle income countries, such as, like Argentina, in Namibia, and South Africa. So there's quite a bit of research on the South African case and the Brazilian case, right? So the difference or the contribution of overall of this research project is that we worked with the government to introduce the program with them. So we did surveys before the introduction, and then we followed, and we have panel data where we follow people through time. So we conducted 3 randomized controlled trials where, again, we have treatment and control groups in the south of Mexico. And so we have different, we did different experiments because we have different implementation designs. So the program I'm going to talk about briefly is about the monthly program. So where the money was disbursed every month. This is for older adults 70 or more. And the pension or the non-contributory pension is $78 purchasing power parity. So it's a flat amount, a flat rate. It's quite small, and we were like, when we did the proposals for this project, we didn't know it's a risky project because we don't know if this small amount of money is going to make a difference in the lives of older adults because of the different pattern of chronic conditions and this is equivalent, but it's quite a large subsidy. It's equivalent to 28% of the minimum wage and also 55% of the median household income. So it's only conditional on age, and it's not correlated to any other observable or unobservable characteristics. We're grateful to the National Institute on Aging from the US, the Mexican government state of Yucatan, and the RAND Center for the Study of Aging. So this is just to show you, this is the map of Mexico, and this is where we conducted the experiments. So we did them in 3 different cities, and we have these 3 experiments, one that started in 2008, another one in 2009, and in 2010. So I'm going to mention some of the results that we have for the 2008 experiment, and then I'm going to talk about the paper we're working on with experiment 2 and 3. So, and to tell you briefly, we did the same in all the experiments. So we interviewed them before the introduction of the non-contributory pension, and then we followed individuals approximately every 6 months. We introduced a survey similar to the HRS, the Health and Retirement Study for the US, but the Mexican equivalent, which is the Mexican Health and Aging Study. So we have in-person interviews, but we also have biomarkers and anthropometric measurements. We also conducted a community price surveys, like prices or like other community infrastructure, to see if there were any, anything else that may be affecting the results of the experiment. In Mexico, so we had the questionnaire in Spanish, but then we realized that when we were doing pilot testing, that about 70%, well, according to the census, reported speaking an indigenous language. And so when we did the pilots, we realized that many of them, Spanish was not their primary language. So we decided to hire translators, and then, we would do the pilot testing with the translators, but we really didn't know what they were saying because, even when, like, I tried to learn Mayan and I got a really big dictionary, very, very different to Spanish. So we couldn't really make sure, that it was the questionnaire, the fidelity or the the questionnaire was going to be applied in the same way. So we decided to translate the questionnaire to Mayan, hire bilingual interviewers, and hire also a person who was like an expert on Mayan, and he was the one in charge of training the interviewers. And we also did a lot of work in terms of the informed consent. So we also translated it to Mayan, and we worked a lot with the RAND IRB, to develop a consent form that was appropriate for low literate population. So we conducted like a census of about 65,000 households. We interviewed about 16,000 in all the different experiments. And we also interviewed or conducted surveys in about 2,000 grocery stores and establishments. This is a survey that I talked a little bit about, so it's based on the HRS and the MHAS, the Mexican Health and Aging Study. So it has all the different sections that the HRS has, like healthcare utilization, self-reported health, activities of daily living, IVLs as well. And then we also have 13 anthropometric and biomarkers. So back then, when we started the experiment, the MHAS didn't have as many biomarkers or anthropometric measurements, so we adopted those in HRS, and then we added a few more that were relevant, particularly for the Mexican case, like, for example, a blood test for anemia that was, quite prevalent in older adults in Mexico.
Are you collecting information on health of household members?
No, this is like the health and retirement study, which it collects the older adult and the spouse. And we have a household roster information that the older adult responds about the characteristics of the household member. And there's also a financial respondent. So if there's someone else who's, more knowledgeable about finances, then that person will respond to the financial section, because we have a very detailed income and wealth section, similar to the HRS. In the results I'm going to show you, we use difference in difference. So we have, as I mentioned, data before and after for the treatment and the control. Like theta 1 here is going to be the causal effect of the program. We've analyzed, attrition and mortality, and it seems similar in both towns that we're analyzing in the first experiment. In this case, I'm only showing the effect 6 months after the introduction of the program. I won't have time to show all the different, selection or maybe bias issues that we tested, and we didn't find. We used other data sets like census data to see, common trends in the past of the geographic areas we were analyzing, and all seems fine. So just to mention briefly,
the background. So you come into the village, you say, congratulations, your village has been chosen. Everybody here is going to get $78 a month.
Right.
And then you go somewhere else and you say, what? Sorry, we chose somebody else. You guys don't get $78 a month. What's the kind of context?
No, so what we did is whenever we went to a different town, we only announced the program in the town that we were introducing the program, and we first did the baseline survey before announcing anything. And then once we were out of the baseline survey, we have this letter where the treatment groups, and I didn't mention that, that's a great question. So in the structure of the program, I talked to people from Oportunidades or Progresa in Mexico, which is a very large poverty alleviation program. And so we structured in the same way as they did. So they have two different government offices, and I did the same. So with the government of Yucatan, we had in the Ministry of Development those collecting the surveys, but they didn't know they were going to evaluate. We're going to use that to evaluate the effects of the program. And then in another ministry, we have the disbursement, or the group that was disbursing the money. And so I worked with both groups, and the group that was disbursing the money, or in charge of the administration of the pension program, we developed a letter from the government saying, we're piloting this pension program, and it's going to be introduced, by stages. So you were randomly selected, and we wrote it in a way. We also tested it quite a bit because in Mexico, many people play lottery. So we explained that they have basically were introduced to the program by chance, but we explained a bit more like it was like a lottery, and so it was okay. Like some of the government officials were really worried before, like, oh, those that don't receive attention, they're going to complain, and we're going to have a huge problem. So it was very stressful when we were introducing the program because the government officials were very nervous. But then I talked to people from the World Bank, and they said, we have done this in several countries in Central America, nothing, try to develop really well this letter explaining that they were randomly selected.
Thank you.
Unfortunately, everything went fine. So these are the first results. So this is a month, 6 months after the introduction of the program. So we find, strong effects and increase on healthcare utilization, food availability as well. So the HRS does not include like nutrition or a questionnaire. So we introduce this scale on food availability from the PSID. So we found a lower proportion of this is at the household level, reporting hunger spells or not having enough money to buy food. And we found also a reduction in work for pay. So many older adults at age 70, they're still working, so they receive this $78 and they stop working. And in terms of health outcomes, we found some effects of a reduction in anemia of about 10.2% and an improvement in lung function of 8.1% for the treatment in comparison to the control group. So we published these first results in the Proceedings of the National Academy of Science.
Those are percentage of the people who have anemia, for example. Those are not percentage point reductions.
No, it's so this is a 10.2%. That's a good point. Let me remember if I put here in the because I have it in percentage points. So this was I think this is no, you're right. I think this is percentage points.
Oh, it is percentage points.
Yeah.
Okay, so
for anemia, because anemia is a dummy, whether they had or not, because we tested whether according to the hemoglobin levels. If they had hemoglobin levels low, then we would categorize them as anemic. And as this is a dummy, this is in percentage points. So, yeah.
And these households were mostly also receiving the conditional cash transfer progressive opportunities.
I think it's about 7% of the households. So not that many had
because they didn't have age eligible kids, or because they weren't as
most
poor?
likely, I think that on average there are like 3 household members. So maybe the older adult, the spouse, and someone else. But we didn't find that many kids. Actually, one of the results I'm going to mention briefly is that we find that great granddaughters come in the household after receiving the pension. But not that many, were like about 7% eligible for progressive. We also published this paper this year on the Journal of Aging and Health, where we analyzed effects on memory. So we only have, in terms of cognitive function, we have a immediate recall and delayed recall. So this is based on they give the respondents a list, or they say a list of 8 words in this case, and they have to. They ask them, which words do you remember? And they have to say them immediately after they read them, the list. And then about 5 minutes after, and that's going to be the delayed recall, they ask them, which words do you recall from the list I told you about 5 minutes before? So we find actually an increase in immediate recall by for men and women, so by about half a word. Right? It seems that the effects are quite large. When we were talking to people experts like on cognitive function, they say maybe because these are individuals with very low income and low levels of nutrition. If they are improving their nutrition, maybe that's what's happening. So we did some, mediating analysis, and we found that it could be healthcare utilization and also food availability. But we don't have any measures of diet, unfortunately.
So in a way, it kind of makes sense that you gave low-income people money and they benefited from that. And so in some sense, that I totally believe that
It would be shocking.
it would be shocking otherwise.
There's a lot of literature we suggest.
Yeah, so I guess I'm curious how these estimates compare to what we know from observational work. Like, are these smaller effects than we thought would have held? Are they larger somehow? Like, how does it, like, yeah, what is the causal idea?
So when we had a reviewer from the journal saying, well, why don't we discuss that a little bit? And we checked other papers that were analyzing, changes on cognition after an intervention or so for low income or low education adults, and they were more or less also, larger than for a higher income. So they seem to make sense.
And are they smaller than we estimate when we just look at a low income sample and see how much having $80 more a month is associated with improvements in health, just say in an observational regression?
Well, we haven't, so, but that's a great suggestion. So in terms of caregiving, we did not find actually any effects. So we have, in the questionnaire, we know who helps them with activities of daily living or IADLs as well. And we constructed a panel database where we follow who takes care of the older adult at baseline and then how that changes after they receive the pension program. But we don't find, it's mainly one person taking care of the older adult, mostly female. And so the number of hours, really nothing changes. 98% of caregivers are unpaid, and they keep being unpaid even when they receive a subsidy. So this, this type of, at least, in this case, it doesn't seem to be helping, caregiving burden. In terms of living arrangements, we find a small increase, but statistically significant, of average household size of 3%. So it's mainly the group of 6 to 11 years old, and it's mainly females, so girls. Like we have data as well to see what is the relationship, and it's mainly granddaughters and great-granddaughters. And this is particularly in households of older adults 70 to 79 years old. We find no effects on those 80 years old or older. And it's mainly on couples' households, so that they were living alone, and then their granddaughters come to live with them after they receive the income supplement. So this seems, we were like trying to understand a bit more of the literature, and so it seems that couples that receive two pensions, right, because if they are age eligible, they are going to, both of them receive the pension, they seem to be taking care of the granddaughters. And there's some papers for the Mexican case that show that particularly girls are more of a burden for parents, low-income parents. So they are the ones who probably suffer the most in that sense to be able to continue going to school and so on. So maybe they are taking care, and there's other literature that we found that maybe the intention would be that the grandparents have more money, so they help their needy children, right? And there's also evidence for the US that that's happening. There's transfer from the parents to children who needs the most. And maybe, they're not transferring the money to the child, but they are taking care of the daughter of the children, of the child in most need. So that may be the explanation. This is different to what they found in South Africa, that they find that the older adults have more like working age individuals living in their household, and they seem to be the least educated. So, they don't have data on whether they are taking care of the older adults, but that seems that they have a lower opportunity cost to basically live with the older adult and maybe take care of the older adult. So it seems that in this case, it's more about a more altruistic, perhaps, like or like maybe as well to like the risk sharing models where, among families, they insure themselves, when they have, the child has an economic problem, so they are taking care of the grandchild.
My granddaughters, my grandsons, I mean,
No, it's girls.
it's just.
It's girls, so we were puzzled about that.
Do you have data on their time allocation? So are they going to school and are they providing caregiving hours to the grandparents?
We have that. We haven't analyzed it a lot, but yeah, we have that information. And we have, we were able to link to the administrative records of the schools as well to see their, their performance. We haven't done the analysis.
The increase in word recall was relative to a baseline for the same group.
Yeah.
Is this 3% relative to the baseline or relative to the control group?
This is, let me think about that, relative to the baseline in comparison to the control. I don't have the result because I try to like show you all the, is that, because the increase is like, it's in number of family members, so it's the change, the difference in difference would be the changing the number of family members for the treatment in comparison to the control, so that number divided by the average household numbers, a household average number of household members, which is, and then it's 3%. Then, so now I'm going to focus on the paper we're currently working on. So this is about the second and the third experiment. And in this paper, we're analyzing what is the effect of a permanent increase in income on of the older adults on their neighbors. Okay, so we want to see whether there's spillover effects. So in this case, we're analyzing a pure randomized control trial where we have treatment and control individuals in the same block. So one of the main critiques of these RCTs is the potential spillover effects. So we want to see if there are spillover effects, and then see basically what happens to the neighbors when some of the older adults receive the income supplement. So in terms of the spillover effects, so some of the different types of the spillovers according to the literature. So one of them is like externalities, like this paper on deworming, where like if they deworm the treated children, the controls are less likely to have the disease or be infected. General equilibrium effects, for example, if the pension program would affect the local economy, maybe prices increase because there's more money in the economy, so there's an effect on prices. Peer effects that maybe because some of them are receiving the money and they may feel that due to social norms or networks or like as an insurance mechanism, they would be sharing their resources with the controls. And social effects, right? That would be because they may change like the neighbor's happiness or their competitive, they may create some competitive or imitative behavior. And well, and the other option is maybe because they're spillovers, because they are altruistic and they would like to share their resources with their community.
It seems like there are two different things going on here. One is the spillover if some people are treated and some are not.
Yes.
And the other is a kind of aggregate effect.
Yes.
But the kind of policy option is not to treat some and not treat others.
Yes.
So in some ways, that one we're not interested in.
Yeah.
But for the prices, that would be something we'd be very interested in.
I know, yes, it is. And this, certainly, the program, you're going to roll it out, in real life, probably. Well, this is a real experiment, but it's an experiment, but you will roll it to everyone, right?
Yeah.
But here, I think, that's what we were analyzing in the previous one, the effects at the 6 months. Now we're working on the effects at the 18 months, and if we change the disbursement instead of every month, every 2 months. But it's not. So those we've been publishing some of the articles, and now because we have it also in one of the experiments, we have a randomized control trial. We thought, well, first we want to analyze the spillover effects. That is mostly about testing, if this is happening in a pure randomized control trial. And then maybe the relevant question is to see how people behave, right, when they receive a permanent income shock, because most of the literature, let me go to here, most of the previous literature has analyzed how people behave with transitory income shocks. So there's this paper of Kuhn, Kureman, Söderman, and Kaptein, 2011 in the AER, that so they analyzed lottery winners in Holland, and so they have data of the lottery winners and their neighbors, and they find that the neighbors actually do react by buying cars and also by repairing their home and painting their homes. And so they have a reaction, and they explain that by saying they have like an imitative behavior, or they may be like envious somehow, or they may be reacting in terms of what's happening because they have a neighbor that is a lottery winner. There's another study in the Mexican case about this conditional cash transfer program, the Progresa Oportunidades, that is given to households with children. Mainly, the main component is for households with children at schooling age. So, so maybe some of them, when the children stop being at schooling age, they stop receiving the subsidy. And this paper by Angelucci and Di Giorgi, 2009, they find actually an effect in the controlled households. So they find that the controlled households, they basically increase their consumption, they have more money transfer receipts, and they also have a higher amount of loans. They explain this because of the risk-sharing model, saying that those that receive the Progresa Oportunidades subsidy today, they may be lending money to their, to the other households, the control groups, because in the rainy days, they may ask, in the future to, lend them back money. So, so most of these papers analyze transitory income shocks. So we thought, well, we can analyze in this, given the design of the experiment, we can analyze what happens if there is a permanent income shock. So as I mentioned very briefly, so according to the permanent income hypothesis, so there's going to be a change in household consumption when there is an increase in permanent income, not in transitory income. And then the relative income hypothesis would say that your consumption is not only determined by your income, but also in relation to others. Others is satisfaction, or Easterlin's hypothesis that says that your happiness not only depends on your income, but also on the income of those living around you. So just in terms of the background of the conceptual framework. I mentioned already this paper, about the lottery winners, that they do react, the neighbors. And then motives, again, for sharing, maybe altruistic, right? So maybe the older adults that receive the income subsidy, they may be, wanting to improve the well-being of their neighbors. And the risk-sharing model as well that I mentioned, like, they may be wanting, to lend them money or so in order to ask them to lend them back money in the rainy days. So I talked about this. So our contribution on this paper is really analyzing, is not so much about the policy effects of the program, which I talked about before, but it's more about what happens if there's a permanent increase in income. So we analyze, because we have a large set of variables, so we think about, well, how can we test according to the previous papers, right? What have they analyzed to understand neighbors' competitive or imitative behavior? So they analyze durable goods, and we analyze the durable goods that we have on our survey. We also analyze home improvements and whether they receive other public transfers in order to test this hypothesis. To test the unhappiness hypothesis would be, that they will be unhappy because of receiving more income. We analyzed satisfaction and depressive symptoms as well. In order to analyze the insurance mechanism where they insure themselves, we analyze like monetary and in-kind transfers, debts and loans, and food expenditures. So we follow what other literature has done. And in order to analyze altruism, we analyze self-reported health, healthcare utilization, food availability, income transfers, and satisfaction with friends. So this is, the program I talked about, but so this RCT was introduced in the city of Mérida, which is the capital city of the state of Yucatan. And so here we analyze the two experiments, the one introduced in 2009 and the one introduced in 2010. The one introduced in 2009 was disbursed in cash, and the one in 2010 disbursed using a debit card. So we have a double randomization design. So the city of Mérida is the largest city, and it has 8,870 blocks. We randomized, or we randomly selected 13.2% of those blocks. And then about 3/4 of those randomly chosen blocks, we assigned them to the cash experiment and to the debit card experiment. In the cash experiment, we have similar proportion of treatment and control in the block, so about 50-50%. But in the debit card, we assign different proportions, so that we would have different intensity of treatment. So we would have in some blocks like 20% of treatment and 80% of control. In others, we would have 80% of control, 20% of treatment. And then in the a fourth of the blocks were remained untreated, so they are pure control blocks, and we only interview them in the last wave. We wanted to do that because we didn't want to have any survey effects or any other possible contamination. So this is the experiment of Mérida 1. These are the different waves of data collection. So wave 3 is the one we analyze in this paper, which it was done at the same time for both Mérida 1 and Mérida 2. So it's in the same date in 2012, and it's the same date that it was done the survey for the pure control blocks. So the Mérida 1, given that it started a year before, so in wave 3 we're analyzing the effects of the program 26 months after its introduction. And for the debit card experiment, we're analyzing the effects 14 months after. So we also have these prices surveys to see if there are any general equilibrium effects. So we collected data in about 1,426 establishments. This is not, well, it's nicer in the computer, but sorry, it's too light gray there, but like somehow this is like the city of Mérida, and this is where we conducted the surveys. These are, it's corner shops, grocery shops, mini supermarkets, markets, farm markets. So we did basically in every block that we surveyed, we counted those about 8 blocks around that block, and that's where we did a census of the establishments. If there were no establishments in those 8 blocks around the block chosen as treatment or control, then we look further out. And then in the survey, we have about 12 items which have similar quality, right? We didn't want to have a product like coffee that there may be different quality, different brands, and it would be, not comparable data. So we chose like tortillas, right? That tortillas are very much the same in a very upscale supermarket and a very so we try to do that. And
can you give us a sense of the median distance between blocks, for example, from one treated block to another treated block?
So the block is more or less about between 100 or 120 and 60 meters. In terms of the distance between treatment and control, that's a good point.
I see you have 13% of the blocks that you randomized, you said.
Yeah,
so one out of every
spread
13 blocks is going to be somehow in
Yeah.
it. So a kilometer or something. could
Yeah,
be the
probably.
distance
Yeah,
between,
that's a good point to check. Yeah.
Okay.
I have the maps, but I thought I didn't have time to show them. There you go. Yeah. Okay. Well, so we compare so as I mentioned, given that we're comparing spillovers, here we're comparing only controls. Controls in treated blocks and controls in untreated blocks. And it's a very simple regression where it's only differences of the means for the controls in untreated blocks and the controls in treated blocks. Okay? So we have, let me show you the model. So it's a very simple model where y is the outcome of interest or the variables that I showed you. And then we exploit the intensity of treatment. So we ran the analysis with these three options. I'm just going to show you the last one. So first is like a dummy, whether you're in a treatment block or you are in a control block. The other option was the proportion of households treated within block, so that we exploit the intensity of treatment. And then C is the proportion of the amount of money within block, which is the same as saying the total number of individuals treated divided by the total number of age-eligible individuals. And we think this is better because there may be in households, about 22% of households have more than one age-eligible individual. So even when there's one household treated, there's not one pension, but there are two pensions, and that may create more spillovers. So we have a few controls, and we cluster standard errors at the block level, and we correct for multiple hypothesis testing. So this is so some of the results. So first we have the first experiment, the cash experiment, then the debit card, and then pulling both data together. In this one, we find, for example, for the Merida one, for the cash experiment, we find there's a decline in the proportion of households receiving food from government, church, or private. So this is mostly like more like emergency food. We also find, remember, this is the controls in treated blocks versus the controls in untreated blocks. So there is an effect. There seems to be an effect. There is a decline in the proportions of having loans or debts.
Is there also a decline in the transfers from the elderly? What does that mean? That means control members in treated blocks get fewer transfers from
Transfers to the elderly. Transfers from the elderly, yes. So from the elderly to anyone, to their relatives or to their friends and neighbors. So there's a decline. It's marginally, statistically significant. It's not here. We did the whole bone ferroni correction, so the most extreme, just to be on the safe side. So these are the columns of the whole bone ferroni correction. Here you see that these ones. I'm just mentioning the ones that has after. Restricting, correcting for multiple hypothesis testing. But that would be that there's a decline in the transfers from the elderly. We find an increase in food availability in the index in both in the cash and the debit card experiment. We find an increase in the satisfaction. This is life satisfaction, but this is a satisfaction with social contacts and friends. So there's an increase there as well. We find an increase in self-reported health in both cases, and an increase on healthcare utilization in Merida 1. So this seems more in line with the altruistic motive. Because it's improving. If you see some of the outcomes that I showed you at the very beginning that were improving for the as a result of the experiment for the treated individuals. That's why I presented that, so that you have a background of what were the treatment effects. So it's
So if I run a corner store and there's more money on my block, more people are going to shop at my store. I'm one of the people being asked, so I'm going to be happier because I have more customers in my store. And then everybody's living there is going to be dealing with me. I'm happier. There's going to be more frequent turnover in the store. Is that the kind of thing we should be thinking of? Or are you thinking of are you seeing this as acting through the market? Or rather, do you think that the individuals who are receiving the money are actually being altruistic with other people? Or
we think that they're basically altruistic, giving money or paying for their medical, going to the doctor or so we don't find any effects on prices. which is here. So general equilibrium effects, we analyze the effects on prices. We have also, so we have the latitude and longitude for the households, but also for the establishments. So, so what we did is we matched, like for each household, we match the closest store using this GPS, data that we collected, and we don't find any change on this average deflated price. We did like a price index at the block level. We don't find any effects on prices.
Do you have some sense, though, of how many of these control households are producers in the very localized economy of the block? So
Right.
that,
That's a good point.
and these retirees, some of them may still be running a store, or
Right.
they have a family member that's running the store downstairs, and so they're
We
benefiting
only,
economically in some direct way rather than an altruistic way.
we know if they own a business or a farm or like,
Mhm.
and but we find such a like a very small percent that we couldn't analyze the changes. So
But did you have household income as a measure that you looked at?
well, so household income, given that is similar structure as the HRS, we have the income for the respondent and the spouse.
Mhm.
So in addition, we collected salary income for every household member.
Mhm.
And so yeah, but that would be, we haven't analyzed, but I think we don't have other sources of income. We're trying to validate with the census data to see if it's like an accurate measure of household income. But that's a very good point. And we are currently, given that we have the latitude and longitude of each household, we are analyzing with this data where by radius, right? We're trying to see if like within, we analyze within like 150 meters, which is more or less the block size, 300, 500, or 800 meters, how is the spillover? And we have some preliminary analysis. I don't have time to show, but we find more effects at the 150 meters, which is approximately a block, and some at the 300, but then no effects at the 500 and 800 meters. So it seems like it's walking distance, probably their connections. Unfortunately, we don't have a survey on who are their friends, or like that would have been very interesting. And so that's so we think that these results so far, so this is preliminary, that seem to be more consistent with the story of that the older adults are being altruistic, just because of the outcomes that are changing for the untreated in treatment blocks. But we think also, in order to understand better this type of the effects of these type of pensions or non-contributory pensions, we need more data to analyze the medium and longer term effects as well. And that's sure, yes.
I'm curious if there's a meaningful interpretation to the spillover effect being larger for the cash than the debit card fee.
Yeah, so we need to analyze that, and because the cash group, because they're receiving basically the money in cash, the neighbor may know they have more money, or but the debit card, we think that they may be able to save the money in the bank and then withdraw little by little, instead of the 550 pesos, maybe 50 pesos every 3-4 days. And it's probably very different. So maybe the pattern of expenditure as well. So that's something we wanted to analyze on itself, because other programs, like the South African case, they disburse the money with a debit card. But we found that, it was really hard to introduce from the very beginning. That would have cost less, for the government, but they were very low literate, so they didn't know how to withdraw the money from the ATM. But I heard these stories from South Africa that, for example, in the Zulu area, they go with big trucks and with the ATM inside, and they help them withdraw the money. And but it is really hard to implement the debit card with low literate population. And we did some piloting and some surveys on, maybe they had many family members helping them withdraw the money, and then there would be more of an effect in terms of transfers to the family members. So we think it's a bit, it may have different effects.
Is debit card only, it's only ATMs? That's all they can do with it? They can't spend directly from that?
What is it?
No, they have to go to the bank. And that was something they asked us while we were doing the experiment. But then some of the shops and the big shops were like, oh, we're going to give them bargains of doing so and so if they use the debit card here. And so I thought, that's going to actually contaminate, we don't know what an effect it's going to have. So we didn't allow them. They basically could only go to the bank or to the ATM of the banks.
How did your program achieve permanent status of an income supplement, and what would be the effects of that? Would it mean that you're having a continuing permanent experiment?
So how did you?
You said that it was a permanent income supplement as compared with other experiments that have done a temporary income supplement.
Yeah, so this was like, so it's given until they die, basically. And so even when it was a pilot program, the government said they would test and pilot it and, in order to introduce it to the whole population. And so even that, so we were working with the government. Every year when I have to report the advance and the progress and what were the effects of the program, they would increase the budget of the program. So that's why we had a new experiment, because they have to pay the people in the previous one and then the new one. So it was quite stressful because we had to report to the governor, this is working, and then it's worth investing, because she was taking the money from other social policies. And so whether it was worth or not. So then that's when they allowed us, okay, you can open a new one. And then, you have this amount of money, and that's why we have a specific number of treatment. And that's how we start. And then I think a few years later, the governor made it as a program, approved by the local congress.
I may have this wrong, but my sense is there's decent literature that suggests that transfers to men and women are spent pretty differently.
Right.
In some cases, there's the Shelley Lundberg study in the
Yeah.
UK, and I thought there was South African pension results on grandmothers and grandfathers, but I
Right.
had that wrong.
Yeah.
So do you
Yeah,
see
there
any such effects here? Do you see different, particularly on the peer effect, like positive neighborhood spillovers?
Yeah, that we still have, because this is kind of preliminary, we still have to analyze. In the other experiments, we find, so I didn't have time to show, but we had another experiment where we disburse the money every 2 months. In that one, we don't find any effects on healthcare utilization. They're basically using the money to buy durables. And so we find very different effects even there for men and women, how they spend the money. There are more transfers from women to, interfamily transfers. In the monthly program, we find a stronger effects on health on women in some aspects. We think that it's because women don't have other sources of pension income. Men, some of them may have access to Social Security, or they may still be working or so. But it's interesting because the situation, for men, even if some of them may have some sources of income in their retirement, and women, if they're not married, they may be living with their relatives. They may also have a good living standard in terms of food availability. They don't suffer as much hunger spells as men, because men tend to live on their own or with their spouse. Instead, women are with their family members, so the effects are different. Yeah, that's a good question. Yeah.
You mentioned in the design that there wasn't a mortality effect. Were you
Okay.
able to measure that and see whether,
Yes. So
was
at
there
the
an indirect mortality effect?
At the 6 months, we don't find any effects. We're currently analyzing if at the 18 months, we seem to find a very small but statistically significant difference for the treatment in the monthly program, and no effects on the every 2 months program, because there were no effects on health basically on that program. And that's most poverty alleviation programs or these non-contributory pensions, like in the federal government in Mexico, disburses it every 2 months. I think that South Africa, most of the countries disburse them every 2 months, these programs.
Those cognition effects were humongous.
The cognition, yeah.
Yeah. So can you give us just a sense of, again, the effect sizes?
We analyze the effects at this is at the 6 months, but we analyze the effects at the 18 months.
Mhm.
And we see that actually that there's like a kick, there's an increase at the 6 months. So in terms of the control, they also continue declining because at this age there's a decline, but they are at a different level than the controls. I don't know if that's, that's such an effect to later affect, cognitive function in general, or even decrease,
And this is
dementia
a
or
3-word recall battery, or how many word recall this?
8 words. It's like the M has.
So the mean is 2.6 out of 8 words, even for the immediate.
Yes, exactly.
And then,
It's very
and
low.
delayed recall was what, 10 minutes or something like that?
About 5 minutes.
5 minutes? With 39% effect, I would.
Yeah.
Do the interviewers know whether the long-term treatment is controlled?
The interviewers know because we had the other, government agency that knew who were the people. They didn't know that the people doing the survey.
Oh,
So
they
we
didn't know.
managed like a separate programs, and we didn't tell the ones doing the survey that they were analyzing or evaluating prevention programs. And back then, the governor had a lot of like social policies going on, so nobody knew what was like. There were programs right and left, and so it was not clear that it was a specific.
So are they drinking coffee?
Yeah.
I mean, if you're getting the program, when the interviewer comes, then do you serve tea and cookies? Is there different
There's
context?
such a, but I don't think it would be different, right, for treatment or control, right? Unless they have more money.
You're giving me the money and
Coffee, right?
Yeah.
And that would be a pattern. We have like a, we have at the end of this section, the interviewer like says, is there any family member? Because we were worried that, there was a family member telling them, strawberry or whatever the word was, or trying to help them respond. But we, so we collected that information specifically, and we like took out those surveys that we thought may potentially had a problem, but we still find strong effect. And we do observe still the effect at the 18 months, so it's, it's puzzling. And we didn't include any other, because we didn't have as much time. We did this in 2.5 hours with the biomarker, so we only added this in terms of cognitive function. We don't have any other tests.
Are the women in the study older than men? These are the eligible, just have to be over 70, right?
Yes. So let me recall, the women older, let me think. So I don't remember right now. That's a good point because that
I'm
would
just curious,
matter.
their effects
for
are
the-
larger.
Yeah. No, I don't think so, because when we analyze age, but I'll check. I didn't put all the tables here because I thought I didn't have time, but that's a good point to check.
Another also like this might be kind of emotional, like a little more money coming in,
Yeah.
and like in terms of like, did you collect stuff about like symptoms?
Yeah. So it seems that depressive symptoms decreased a little bit. We're currently analyzing that scale. It's different, the effect for men and women. So we also have a life satisfaction scale, like income, your friends, your work, and we find some effects like they are more satisfied with their income. In some cases, like I didn't show all the results, but I think we in the monthly we obtain like a little bit more satisfaction on their health. We find in the every 2 month program they are less satisfied with their family and friends. We think it's because given that they have every 2 months, so they have a higher chunk of money, and they're not probably their relatives know they're probably lending money or.
Okay, thank you so much.
That's really cool.
Thank you so much.
So,
thanks for
Or you have your granddaughter in the household, and that could be another mediator too.